Welcome to The Explainer, where we're going to visually walk through the core concepts of pediatric cardiovascular problems, step by step. Our goal is to really map out the why behind the symptoms so you can practically see the pathophysiology unfolding in your mind. Let's get started. So here's our roadmap for today. We're going to start with the basics, the heart's normal blueprint. Then we'll look at three big problems: too much traffic, roadblocks, and messed up routing. We'll see how they all tend to lead to heart failure, and then we'll cap it off with the critical nursing responses you absolutely have to know. Okay, let's dive right in. Before we can even talk about what goes wrong, we have to get a rock-solid understanding of what normal looks like. And when it comes to the heart, everything, and I mean everything, boils down to one simple rule about pressure. Here it is, the one rule to rule them all: blood always flows from an area of high pressure to an area of low pressure. It's just physics. Think of the left side of the heart as this super strong, high-pressure system. It has to be, right? It's pumping blood to your entire body. The right side, though, it's a low-pressure system. Its only job is to give the blood a little push next door to the lungs. This pressure difference is the key to understanding literally everything that follows. So what happens when we mess with that perfect blueprint? What if there's an abnormal opening, a hole, a leak, somewhere it's not supposed to be, connecting these two different pressure systems? Well, that opening creates what we call a left-to-right shunt. And if we follow our pressure rule, what's going to happen? That high-pressure left side is going to force blood across that hole into the low-pressure right side. And this sends a whole flood of good, oxygenated blood on a useless trip back to the lungs. It's like a massive traffic jam on the highway to the lungs. Let's trace this whole chain reaction using a classic example, a ventricular septal defect, a VSD. That's just a fancy name for a hole between the two bottom chambers. So step 1, you've got a hole. Step 2, the high-pressure left ventricle shoves blood through it. Step 3, all that extra blood overloads the pulmonary artery and just floods the lungs. And the end result of that whole domino effect: the lungs get congested, the right side of the heart gets totally overworked, and it all leads to signs and symptoms of heart failure. So what are you going to find when you assess a kid with this kind of problem? Well, you'll definitely hear a murmur from all that turbulent blood flow. You'll see those signs of heart failure because of the volume overload. And with one specific type, a patent ductus arteriosus, you'll feel these classic strong, bounding pulses. You've got to know those findings. Okay, let's move on to problem number 2. So instead of a leak causing way too much traffic, what happens if there's a physical roadblock, a blockage in the system? We call this roadblock stenosis. It's just a narrowing in the anatomy, usually near a valve, that physically blocks the flow of blood. Now, the chamber right before that blockage has to pump like crazy with incredible force just to squeeze a little bit of blood through that tiny opening. And that, as you can imagine, creates a massive pressure backup. Coarctation of the aorta is the perfect example of this. You've got a pinch point in the aorta, the main highway for blood leaving the heart. Blood can't get down to the lower body very easily, so pressure backs up behind the roadblock, which gives you high blood pressure and really strong bounding pulses in the arms. But downstream from the block, you get the exact opposite: weak or maybe even no pulses in the legs, and they'll feel cool to the touch. It's like a tale of two completely different circulatory systems in one body. And all these assessment findings are the direct logical result of that physical blockage. That stark difference between the pulses and blood pressure in the upper and lower body, that's your number one clue for this condition. In older kids, all that high blood pressure in the upper body can even lead to things like headaches and nosebleeds. All right, on to our third and final type of problem. This is what happens when you combine the last two things we talked about. What happens if you have a roadblock and a leak at the same time? Well, you get a really dangerous situation where the blood flow gets completely rerouted, mixing the blue deoxygenated blood with the red oxygenated blood. We call this a right-to-left shunt. Here's how it works. You have a roadblock, like a narrowed pulmonary valve, that makes it incredibly hard for the right ventricle to push blood into the lungs. The pressure on that right side just builds and builds and builds until, boom, the pressure on the right side is now higher than the pressure on the left. So now, if there's also a hole, like a VSD, that powerful right side is going to push blue, deoxygenated blood right across to the left side and out to the body. And that's what causes cyanosis. The absolute classic textbook example of this is tetralogy of Fallot. It's like the perfect storm of 4 different defects all working together. You have the pulmonary stenosis, that's the roadblock building up the pressure. You have the VSD, that's the leak that allows the blood to shunt over.
You have an aorta that's sitting right over that hole, making it super easy for blue blood to escape. And finally, you get a thickened right ventricle, which is just the evidence of how hard that poor chamber has been working against the roadblock.
So this leads us to a really critical clinical question. When a baby with this condition suddenly becomes very blue and distressed, an event we call a TET spell, what is your first move? This is a true emergency, and what you do in those first few seconds really, really matters.
Your response needs to be immediate and automatic. First, you've got to calm the baby down because crying just makes it worse. Second, and this is the most important part, you put them in the knee-chest position. This simple little maneuver kinks the blood flow to the lower body, which actually increases the pressure in the systemic circulation. And that higher pressure helps force more blood to go down the correct path, into the pulmonary artery, instead of shooting across the VSD. After you do that, then you give oxygen and call for help.
So, as you've seen, whether it's from too much traffic, a major roadblock, or a complete rerouting of blood flow, a lot of these paths lead to the same final destination. The heart just can't keep up with the demand. It goes into failure.
Now, for any exam, you have to know the difference between left and right-sided heart failure. Here's a simple way to remember it. Left-sided failure backs up into the lungs, so you get all the respiratory symptoms: crackles, cough, trouble breathing. Right-sided failure backs up into the rest of the body. That's where you get the systemic issues, like swelling in the legs, a swollen liver, and weight gain from all that extra fluid. And speaking of weight gain, you need to tattoo this number on your brain. A sudden weight gain of 0.5 kilogram, which is about 1 pound, in a single day, that is not from the baby having a big meal. That is fluid, and it is a massive red flag that the heart failure is getting worse. You have to report that immediately. Okay, let's bring it all together and wrap this up by connecting all this pathophysiology to what we, as nurses, actually do about it. How do we manage this failing heart?
So when we're managing heart failure, a go-to medication is digoxin. It helps the heart pump more effectively. But it is a tricky drug with a very, very narrow margin of safety. So the number one golden rule is you must check the apical pulse for a full minute before every single dose. And you have to know your heart rate cutoffs for holding the medication. For infants, that's typically anything below 90 to 110.
And it's not enough for us to know these rules. We have to drill them into the parents. They need to know this stuff inside and out. If the child throws up after a dose, you do not give another one. Never, ever double up on a missed dose. And they have to be watching for those early signs of toxicity, which can be super subtle, like the baby just isn't feeding well or is vomiting. Now, we also use diuretics, like furosemide, to help get rid of all that extra fluid. But here's the critical connection, the point you cannot miss. Diuretics often make the body lose potassium, and low potassium or hypokalemia makes the heart way more sensitive to digoxin. It dramatically, seriously increases the risk of toxicity. You absolutely have to remember that interaction. So we've traced the entire chain reaction, from a simple hole to fluid in the lungs, from a narrow vessel to different pulses, and from a complex defect to a blue baby. Now the final question is, how does being able to visualize that whole cascade help you decide what to do first when you walk into a patient's room? Because answering that is what turns knowing the pathophysiology into life-saving clinical judgment.